Now, supracondylar humerus fracture is one of the most common fractures we see in our day-to-day practice. Now, a quick show of hands. These are X-rays of two different patients. How many of you will operate on these cases? Yeah, very few. Yes, most of you think they are very innocuous and they can heal conservatively. But if you miss this, this is going to be the end result. They are going to create, of course, a cosmetic deformity. The more important thing is this will predispose to lateral condyle fractures in future age. There is a cubitus varus hyperextension. Now, this already Dr. Vidyasagar has explained the importance of how to take proper X-rays. Everyone knows the Gotland classification. First is incomplete fracture and type 3 is complete fracture. The type 2, the posterior cortex is intact. This is what originally Gotland described, and as you can see, the posterior periosteum is only intact in type 3, whereas the anterior periosteum is completely torn. Now, Wilkins modified this. He subclassified type 2 into A and B. In type 2A, there is no rotation or translation, just a pure extension. The anterior cortex alone is breached. As in type 2B, there is associated with translation or rotation. This is the Rogers line. This is the most important radiological finding you have to see. See, whenever you draw the anterior humeral line, usually it will cut the capitulum. In an extension type fracture, the capitulum will go posteriorly, it won't cut. Now, we will deal with the importance of this anterior humeral line later on. This is a very simple algorithm by Professor Teddy's Longo in how to classify the fracture. It will take hardly 30 seconds to classify a fracture based on this algorithm. First, if the fracture is complete or incomplete. If the fracture is complete, then is there any contact? If there is some contact in a complete fracture, it's type 3. If there is no contact in a complete fracture, it's type 4. In type 1, the anterior humeral line will cut the capitulum, whereas in type 2, the anterior humeral line won't cut the capitulum, or there will be a varus valgus gap of more than 2 mm. This is the slide. Now, AOS has recommended that you fix every displaced supracondylar humerus fracture. It means even type 2, type 3, flexion type supracondylar, displaced type. So, you have to fix everything. But if you fix everything, there will be is going to be a over indication, like more than 70% of unnecessary cases will also be pinned. But then how to know whether this closed reduction conservative management is going to fail or not? So, this is a good article by Fitzbiggins. So, actually he described the anterior humeral line index. See, in the first X-ray at presentation, it was the anterior humeral line is not touching the capitulum. But once you do a close reduction, it was touching the capitulum, the reduction was very fine. But after a week, as you can see, it has gone back. So, what is happening? So, the anterior humeral line index at the time of presentation is very important. At the time of presentation, if it is not touching the capitulum, it means already there is a hyperextension. If there is a higher anterior humeral line index, then it means the extension deformity at the time of presentation is higher. It means the soft tissue disruption is also extensive. If there is an extensive soft tissue disruption, then there is a less support to maintain the reduction. So, there is a very high rate of failure. So, always believe on the X-ray at presentation, not the close reduction X-ray. Now, Kang et al., they have shown that if there is a low supracondylar humerus fracture, low fracture is in the lateral view below the hourglass line, you will see the fracture, AP view below the transepicondylar axis. So, let us take a case example. So, this case belongs to Dr. Kailash. So, you can see in the low supracondylar fracture, the distal fragment is very small. First of all, it is very difficult to reduce. Even if you reduce, it won't stay there. It is difficult to pin also. So, such fractures are usually associated with disruption of the capsule ligamentous complex. So, most of the low supracondylar fractures have to be treated surgically. And of course, you will need orthogram. Now, this is the first X-ray which I have shown in the initial slide. See, the most important thing is this is looking innocuous. And even the lateral view is looking like a type 1. But the most important thing is this, the medial comminution or a varus impaction. So, in this paper by Debog, actually has shown that all those fractures with the varus impaction and medial comminution, they go for this cubitus varus deformity. They definitely need pinning. But can some fractures be treated non-operatively? Then what is the real indication? So, this is a very good paper published in JPO 2012 by Spencer et al. Here, he has given some few indications where you have to, first is excessive swelling. So, you will not be able to position the limb at all. You cannot flex the limb, hyperflex. Second is if there is any varus valgus or rotation involved. And then comes the shaft condylar angle. So, Dr. Vidyasagar told you the shaft condylar angle is around 40-45 degrees normally. But if it reduces to less than 15 degrees, then you have to. As you I have shown one case where initially the reduction was good and then you are having loss of reduction. So, all these cases have to be pinned. So shaft condylar angle, if it extends further, the angle is going to reduce. Again, this is similar to the HLI, the anterior humeral line index. So initial deformity is more than the soft tissue is poor, you have to fix them. So all these things told you when to fix. Now this fracture configuration is going to tell you how to fix. So this is a paper by Bock et al. From Johns Hopkins. They have shown the patterns of supracondylar humerus fracture. The medial oblique pattern, the lateral oblique pattern, and the high supracondylar. See, it all depends on where the fracture line exists. If the fracture line is exiting proximally, medially, then it is a medial oblique fracture. If you try to pin this only by lateral pinning, this is never going to fix it properly. It will be highly unstable. So they will need a medial pin. Similarly, a lateral oblique fracture, proximally the fracture line will exit laterally. Such cases can be treated by lateral pinning. Now, the anterior humeral line, the capitulum is going anterior to the anterior humeral line. So these are flexion type injuries. Flexion type injuries, especially displaced fractures, may be probably a type 4. So all these flexion type displaced injuries have to be treated by surgical means. So what is type 4? So type 4 is a multi-directionally unstable fracture. When you flex the elbow, it will look like flexion fracture. When you extend the elbow, it will get converted to a extension type fracture. They need special techniques which they will discuss in the next lecture. Also, whenever you see a pucker sign, it indicates that there will be some impalement. So the fracture fragment will pierce through the brachialis, you have to milk that to get a reduction. Sometimes in irreducible fracture, you can palpate a sharp spike subcutaneously. Whenever you are palpating a sharp spike subcutaneously, you should have a low threshold for open reduction, because most of the time there will be some impalement of the soft tissue structures. In a posterolateral type, the medial spike will be injuring the medial nerve or brachial artery. In the posteromedial type, the radial nerve can be involved. Now, this is a special pattern. Normally, when you see a supracondylar fracture, it's a hyperextension injury. The fracture line, it actually starts distally anteriorly and progresses posteriorly proximally. But reverse oblique pattern, it is a reverse. So here, the fracture line starts from anteriorly in the proximally and then it progresses distally posteriorly. So such patterns, if you go for the usual Blount's technique of reduction, it won't reduce. So if you initially reduce the translation and then if you flex, it is going to impinge, it won't reduce. Initially you have to displace it anteriorly and then you should correct the translation. So take home message is a proper X-ray is important. You have to do a proper clinical radiological analysis, classify properly, and configuration of the fractures are also important in planning the fracture fixation. Finally, don't forget to recognize the special and unusual fracture types. Thank you.